Welcome to Ask the Experts, presented by Salinas Valley Memorial Healthcare System. I'm Claudia Otero. We are continuing our Heart Health series this month, and today we're focusing on the pandemic's toll on heart health. Joining me today is Dr. Vincent DeFilippi. Thank you for being here today.
Oh, thanks for having me.
Well, thank you. Well, let me just tell you a little bit about Dr. DeFilippi. He is the Vice Chair of Surgery and Cardiac Surgery at Salinas Valley Memorial Healthcare System, or SVMHS, and he has been with our staff since 2008. He is a nationally recognized leader in heart surgery and has performed thousands of open heart surgeries. He has extensive specialized experience in valve repair and replacement using minimally invasive techniques, and has pioneered several minimally invasive cardiac surgery procedures. We are so grateful that you have dedicated some time for us today to answer some very important questions. So again, thank you for being here.
Oh, my pleasure.
Thank you. Well, I guess we'll begin. We've been hearing a lot about this the last couple of years during this pandemic, but the first question would be, how does COVID-19 impact the heart?
Yeah, COVID-19, when it impacts the heart, can cause what's called a myocarditis. You get inflammation of the heart muscle, and in some cases it can be life-threatening. So it's really important to, continue all of the measures to prevent getting COVID in the first place, because the life-threatening potential of myocarditis
Can be deadly.
Yes.
Okay. All right. And according to the American Heart Association, there are reports of people contracting COVID-19 who don't have underlying health conditions. And what's being said is that they are developing, and I think this is what you were just talking about, the arrhythmias. Can you elaborate a little more about that?
Sure. I mean, the myocarditis basically is the muscle of the heart. The heart is a muscle, and when that heart muscle gets inflamed, the inflammation of it is called myocarditis, and then the conduction tissue of the heart goes through that musculature, and when it gets affected, you can get arrhythmias, but you can also get necrosis. It can kill the heart, the muscle. It can make it very weak, and that's why any of these things can be potentially life-threatening. So it's definitely a big concern, even if it doesn't happen that often. The gravity of it warrants avoiding it.
Okay, so again, it's really important that we all take those steps to guard our health.
Masks, everything.
Good. Okay. I want to move on and talk about children, because some children who have been infected with COVID-19 have developed what is known as MISC, if I'm saying that correctly, multi-system inflammatory syndrome. Can you elaborate on this? What is it and why is this happening?
Well, again, it's the inflammation that the infection is causing throughout the body. We're talking about the heart today, but really this is a total body that gets in your system. It can go to any organ, and the heart is included in this. But this is a process that can damage every organ in the body. It can go to the brain, it can go to the kidney, it can go anywhere. And so because of this is all of the concerns. And in children, again, it can be devastating.
Okay. Do you know, what are the studies now? Is this something that children are getting better? Does it go away, or?
A lot of it's still unknown as far as long-term effects. Obviously, at this point, it's only a couple years into the process, and to know how this is going to affect them long-term is difficult to know. It's unknown. But with other diseases of the heart, when you can get viral infections of the heart, they can be permanent, and they can go to causing people to need transplants and things. So viral infections in the heart can be things that will affect them for the rest of their lives.
And that could be somebody who's as young as 20 years old versus somebody in your...
Yeah, sure. You get viral infections at any age.
Okay, so obviously that's going to have a huge impact on the quality of your life moving forward.
Oh, it changed everything, yeah.
As we begin the third year of this pandemic, we've been saying from the very beginning, you need to take precautions. You need to go see your doctor. Do not delay care. It's been happening. People have been delaying care. What have you seen, in terms of your patients who have done that?
This has probably been one of the hugest problems with COVID as it relates to a lot of diseases, and especially the heart, in that people have been so worried about going to the hospital because they figure, well, anyone who has COVID who's really sick is in the hospital. And so they say, I'm going to avoid going to the hospital. And they sit at home and they have heart attacks, and people are dying or coming to the hospital much sicker because they've delayed coming to the hospital because of fears of the hospital. The hospital is one of the safer places to be in that everybody that walks through the doors is either tested or vaccinated. I mean, they've limited all kinds of visiting restrictions and hours, and so the hospital is a safe place to be. But everybody has this perception that the virus is just all over the hallways and everywhere, and they're going to avoid it because they don't want to get it. Any of the patients that have it, there's a special ward. They're sequestered off while they're infectious, and anytime that they even go to x-ray or anything, the hallways are cleared. I mean, there's nobody can get near anybody who actually is actively infected. So the hospital is a safe place to be for this, and that the people who are delaying coming to the hospital when they need to come to the hospital are dying. I mean, the patients that are coming for heart surgery are much sicker because they've waited so long, had bigger heart attacks than they needed to, or they just waited to see their doctor, or whatever the circumstance is, just making the situation riskier. And this is a national problem. It's not just here. I mean, everywhere we're finding that the people are sicker and people are dying from heart disease that don't need to.
Yeah, and that's the honest truth right there. You just heard it from one of our cardiothoracic surgeons. Please do not delay care. Now, we should also mention that 100% of our staff is vaccinated. So again, if you're afraid of contracting it, we're taking all the precautions. We're all vaccinated. Don't delay care.
Yeah, everybody's vaccinated, and everybody that enters the hospital is vaccinated or tested, and you can't even get through the doors without some.
It's a fortress. In a way. Thank you for that. I do appreciate that. I want to switch gears a little bit and talk about heart disease. It is the leading cause of death in women in the U.S. So why is that?
Well, it's the leading cause of everything in the U.S., so it's men and women. I think that there's a perception that men are affected more and women are affected less. And that's not entirely true. I mean, there's some effect that may be protective of women premenopausal, that some of their rates of it are lower, but they catch up. And it's still the #1 killer of men, it's the #1 killer of women. Okay. And so it's important for everyone not to say, you know, I'm a woman or I don't have it in my family or whatever it is, that they need to be checked out regardless of what gender they are.
Okay, and what are those signs and symptoms? And are they different for men and women?
So it's interesting that the signs and symptoms, there's a whole spectrum from people who have no symptoms at all, and it's found out because of the sophisticated testing that we have, and you know, people's index of suspicion because they have risk factors, to people who, just like on TV or in the movies, are grabbing their chest saying, call 911. But there's lots of people that are in between. And so it's important that, you know, any kinds of symptoms, people sometimes just don't feel right. I mean, you know, heartburn is called heartburn because it mimics having a heart attack, and it's just reflux, and people do sit on their sofas saying, I have heartburn, and take Tums and have big heart attacks watching TV on the sofa because they don't come in, they don't think about it. And so it's important that it's known that it's not just like in the movies or on TV, that you can have a whole range of potential symptoms. Now, sometimes the concern is that it's detected a little bit later in women. So when you talk about women, okay, it's not that they have it less often, it's just that sometimes it's detected later, and there's a lot of theories on why that is, but it doesn't mean that everybody's gonna be grabbing their chest. A lot of people get short of breath. If you have diabetes, it affects some of the nerves to the heart. You don't get pain the way that other people do, and so it tends to be more short of breath. But then there's people that we find that need heart surgery that have, you know, really potentially life-threatening blockages in their heart arteries that it's found only because they go and get a stress test. And so that's why kind of going and seeing your doctor and getting evaluated, and they'll figure out if you need to get further testing. but there's a whole spectrum of ways that people present with heart disease.
And if a person goes a whole year without going to see their primary physician, or maybe even two, as has happened during the last 2 years of this pandemic, that could be one of the consequences.
For sure. I mean, I just operated on somebody who didn't go to see his doctor because he was all worried about, getting out and going to a doctor's office where there might be other people, and he could have sat home and had a big heart attack and died. And fortunately, he was diagnosed early enough where we were able to do his surgery, and he's doing fine. But the point being that people were delaying all aspects of their kind of self-care that were important.
Right, right. And we do want to reiterate that we do have telemedicine. So for some of these appointments, you can just meet with your physician that way.
Yeah.
And have those appointments. So, well, thanks for that. When does a person actually need to have open heart surgery versus the minimally invasive procedures?
Well, basically there's the whole gamut when you have heart disease of sometimes you just take medications, sometimes you get a stent put in, which would be through the leg, and then other times you need to have open heart surgery. Usually people that are having open heart surgery, it's because of the types of blockages or the number of blockages that they have. What the data has shown is that people that have diabetes especially benefit long-term from having heart surgery. So it's kind of like most people don't want to go and have heart surgery, but when you look at the data and you go, well, you could have nothing or you could have a stent, but 5 years from now, 10 years from now, your chances are 40% higher of being alive if you have surgery. Then a lot of times they say, oh, yeah, I want that choice. And so for heart surgery, it's usually the types of blockages, the location of some of the blockages, and then again, some of the comorbidities, and especially diabetes being a big one.
And we're going to talk about diabetes in a moment here, but again, the best way to prevent having major heart open surgery, right, is?
For sure. There's certain things that we can change. Your diet, exercise, and not smoking is a huge one. And there are certain things that we can't change, at least yet. Your genetics, if it's in your family, and if you're a male and you're younger, can't change that. And then there's a few that we can work on, things like stress, and try to get into some ways of de-stressing or mentally, because those are all risk factors for getting heart disease. And so, but going for the ones that we can do something about, the diabetes, your high blood pressure and your smoking and all that stuff, and your cholesterol, getting that checked and under control is going to help you avoid having to have something like heart surgery.
Okay. And you mentioned diabetes, and a while back I remember you telling me that your patients nowadays are a lot younger than they used to be 20 years ago, 10 years ago.
So what we're finding is that with a lot of younger people and the diet and the obesity sort of epidemic that we are seeing right now, that these people are becoming diabetics at younger and younger ages. So if you have a bad diet and you're overweight and you go and start to have diabetes and need medications, it used to be they were coming in 50, 60, 70 and starting their diabetic medications. Now they're coming in 20 and 30. So by the time they're 40, they've already been a diabetic for 20 years. And those 20 years have the same effect as in the past when you started having diabetes at 45. So maybe you come in at 65. Now you're coming in as a diabetic at 25. Well, 20 years of diabetes, you're 45 and needing heart surgery. I mean, we've operated on people at 30, who have needed open heart surgery for bypass surgery because of the effects of, combination of diet, exercise, obesity, and sometimes family history. And the patients are definitely getting younger and younger and bigger. And the percentage of our patients that have diabetes now is 50, 60%.
Yeah, that's an alarming number, an alarming reality. But a few years ago, you performed a triple bypass on a 98-year-old man from Salinas. We want to share that story with you now.
How you been?
How you doing?
Oh, it's so good to see you.
Good seeing you again.
Yes. It's been what?
Seeing you again,
it's been a year?
I'm David G. Perez, and I'm 99 years old. I'm here at room where I had my surgery for my heart. I came out real good.
He was having falls, he was dizzy. When we brought him into the ER, he was having severe chest pains. He'd had 3 heart attacks that night.
The reason was that my arteries weren't giving enough blood to my heart. They were rotten, they were bad.
All the main arteries in his heart had severe blockages on them. As we were trying to decide whether he was strong enough to undergo a bypass, I was seeing videos of him dancing at weddings and things, and so I knew that if we could get him through the surgery, we could get him back to that again.
He was very optimistic about doing it. He's a World War II veteran, and so he's tough.
I said, okay, I'm strong, I can do it. A big decision I made, and it was the right decision. I had 3 bypasses.
A bypass is you reroute the blood flow to the heart. So you take a vein or an artery from somewhere else in the body and you sew it in on the other side of the blockage so that it goes around the blockage.
The care they gave you here at the Salinas Memorial, it's wonderful. They're all treated so good and so nice.
He went to the rehab and he did extremely well. We came home, he did everything that he was supposed to do, and ultimately here we are at 99, literally planning his 100th birthday.
We're going to have drinks, food, and music. Everybody's invited. I'd love to dance. Come on, sweetheart, let's go.
So I love seeing that video of Mr. Pettis dancing with his daughter at that wedding. And actually that happened just a couple of months before you operated on him.
So every 98-year-old is not the same, and we don't operate on a lot of 98-year-olds. And in his case, one of the things, as we were discussing what the surgery would entail and recovery from it, he was already in the hospital and he was sitting in the bed. So it's hard for me to really get a feel for when he says he's active. You know, anybody that's 98 that can walk in their house is considered active. So, but to get a real feel for it, they showed me that video and I saw him dancing, and so I realized that, you know, we could get him back to that. That was just, you know, a short time ago. And, you know, we went for it and he was amazing. And here he is, I don't know how years later.
Yeah.
And
Yeah.
yeah, so I think that was definitely the other end of the spectrum, as far as we have patients that are 30 and we have patients that are 98. So it can really happen to you at any point in time in your life. And that's, again, why going and seeing your doctor, because you don't know where you're going to fall into that range. It's important just to get checked out.
Well, I do want to share with you that, so that was almost 4 years ago. So March 1st, he'll be turning 102. So happy birthday to you, Mr. Pettis, if you're watching.
Happy birthday.
Yeah, and thank you for letting us share your story. It's a wonderful story, happy ending. We're so glad you're doing well, and
Yeah.
happy birthday.
I've seen him enjoying life,
Yeah.
watching the playoffs.
Absolutely, and the Rams won, and that's his team, so he was very happy about that. So let's spend a couple of minutes talking about a bypass. You know, what is it? How is it performed? Can you show us with this monitor here?
Sure. So basically this is the heart, and the heart arteries usually are on top of it here. And basically the heart muscle, the heart's a muscle, gets blood with oxygen in it to do the work of pumping, which is what the heart is, the pump. And when you get blockages in there, the arteries can't supply the blood with the oxygen in it to the heart muscle. And so if the heart muscle dies, that's a heart attack. And so what we can do is, if there's a blockage here, we don't actually remove it, we don't do anything to it, we go around it. That's why it's called a bypass, and we take an artery or a vein from somewhere else in the body, and then we sew it into the artery here. So what happens is if this part of the heart was at risk of a heart attack because there's a blockage up here, then we sew this in here, and now the blood will flow through here and get to that heart muscle to prevent the heart attack or to get rid of the chest pain or whatever's going on with the person. So that's how it's done, and then you do multiple ones here. We usually use one artery that's a branch of this artery over here that goes to the arm, and we put it on here, but that's what a bypass is.
And if it's a case similar to Mr. Pettis where he needed a triple bypass, I mean, how long is that surgery? How long does that take you?
It depends, but case like that, usually the surgery itself, I always talk about surgery time and worry time because the families want to know how long am I going to be worried about them. They want to know how much is surgery time. The surgery is probably about 3 hours, but the worry time is probably like 4.5 hours because of the setup before and after. And so I think the surgery is about 3 hours for that.
TAVR, let's talk about TAVR.
Sure.
So that is transcatheter aortic valve replacement. This is a minimally invasive procedure that is part of our structural heart program at SVMH. What can you share with us?
So basically, the aortic valve is a heart valve, and it has a propensity for a variety of reasons to getting blocked, and gets calcified, hardened, and then the effect it can have on a lot of people is that they'll either get chest pain or short of breath or other symptoms from it over time. And traditionally, what we'd done was we would tell people, well, this is it. We're going to need to do open heart surgery and take the valve out and put show.
Absolutely.
Yeah. So we have these like surgical valves that look. Where are they? They look kind of like this. I don't know if you can see that or not, but. And we have some newer.
Put it up to the camera right here, yeah.
Newer surgical valves that, and it's got 3 parts to it, like the normal heart valve would have. And we would take the heart valve out, and we would sew something that's like this in. And then what happened was in patients, especially who you'd say, well, we can't do heart surgery on you because you're too sick or old or whatever it was. And so they created this device that is basically a valve that sits inside of like a stent. And if you can see that, it looks just like the valve I just showed you, but it's inside of a stent. And you can roll it up and you can put it through the leg artery, and then you expand it, and you don't actually remove the heart valve, you just kind of wedge this inside of it. And initially it was only for people who couldn't have heart surgery, and then it was for people who are high risk for heart surgery, then medium risk, and now it's pretty much for everybody that comes in that has this heart valve problem. There's a few reasons not to put it in, but for the most part, I think right now we're putting about 80% of the valves that we're putting in this way through the leg. And the biggest benefit of it is that most of the people are going home the next day, and recovery is definitely faster than when you have open heart surgery. We don't really have the long-term data, especially on the low-risk patients like we do for open heart. And so, sometimes when people are younger and they just want what's tried and true, that they'll say, I want the other, surgical valve, or there's other indications where we have to do it surgically still, but the majority of the patients now are getting TAVR.
That's fascinating. And you mentioned the recovery. They can go home the next day versus...
most of them are going home the next day as opposed to 4 days or 5.
And being in the ICU too after open heart surgery.
Yeah, after open heart, we're usually keeping them in for overnight as opposed to most of these patients are going right to the heart center.
And is this a procedure that you perform, the TAVR?
It's a team. We have a big team. We have our whole surgical team is in there with me, the cardiology cath lab team, with the cardiologist is also in there. And so we have, if you look down from above, you think we're having a party with all these people in there and anesthesia's in there, and we've got the heart-lung machine ready just in case something happens, and all the nursing and echo and support staff. And so, yeah, it's a definite team effort, just like all of heart surgery always is.
And I've actually been lucky enough to be present in the cath lab when this procedure is being performed, and it really is fascinating to watch everybody working and just how concentrated everybody is. And it really is teamwork. Everybody has a different job to do for that amazing outcome. How long does the procedure take?
Well, the ones we've been doing recently, because we've done over 100 now, and we're getting them in 30 to 60 minutes sometimes, the procedure itself. I mean, sometimes setup for the procedure is actually longer than the procedure itself.
And that means getting the patient ready and the room ready.
And putting them, whatever anesthetic and prepping and all that, draping and stuff like that. So, yeah, it's for the most patients, it's getting a clockwork.
Okay, and obviously a referral would be needed from your doctor to have a patient go see you to see if they're a candidate for TAVR, correct?
For sure, yeah.
Okay. For more information on TAVR, please reach out to our TAVR coordinator. She's Ann Timberlake. She is a registered nurse at SVMH. Her contact information is right there on your screen. You can also email her at atimberlake@svmh.com, and you can also read about TAVR and also other procedures such as the Watchman and MitraClip on our website, svmh.com. Specifically for TAVR, it's going to be svmh.com/TAVR, TAVR. So as part of our structural heart program, we also have the procedure that is fairly new to us, which is the MitraClip procedure. But what about a person who is not a candidate for that procedure? Can you explain, first of all, what this is, a MitraClip, and what this other procedure is that you're going to be discussing?
The MitraClip, the mitral valve has two parts to it. So it's kind of like the saloon doors that open and close. And for some reasons, if those valve leaflets aren't touching each other and there's a gap there, there's going to be leakage, and then you can get affected by that. A variety of things can happen. Your heart can get weak, you can get short of breath, you can get symptoms from it. And what the MitraClip does is it clips those two parts and brings them back together so that they're now coapting and that you get less or no leakage afterwards, and it can help for all those symptoms and things. But a lot of people have leaky heart valves for a lot of other reasons. And in those cases, we're still doing procedures to mostly fix now. And that's been a big change over the years, is that we used to just take the valves out and put new valves in. And we can do that still. In some cases, you have to do that when the valves are really deformed or if they're infected or something. But what we're doing a lot more of is repairing. In fact, most of the patients that I see now that come in with leaky heart valves, I don't actually remove the valve. I fix what's wrong with it. And so I can cut a piece out, or the mitral valve has connections to it, so it's almost like a parachute. And those ropes that would normally be attached to it that are keeping it in place, if they snap, I can put new ones in. And then, kind of using the saloon door reference, I also always put in something that looks like this, which would be kind of like the doorway. So it brings the leaflets back together so that they can coapt, touch each other, and that there's no leakage there. So we still have a lot of surgical options for people who may have leaky mitral valves that may not be candidates for MitraClips.
Are these procedures being performed on children?
Oh yeah, you can do these procedures on children as well. There's so many reasons, congenital reasons, that people can get leaky heart valves when they're infants and newborns. And the repair techniques and the types of things that you have to do for them tend to be one of many things. It's less common to have just the mitral valve as your problem when you have these congenital abnormalities. There are usually other things associated with it. And so that, depending upon what group of issues they have, would dictate what surgery they get. When you hit adulthood, there's less of those are because of genetic problems. I mean, with the aortic valve, when we do TAVR sometimes, or open surgical valve replacement, it is actually something that they're born with. Instead of having 3 parts to it, it has 2 parts to it. They'll come with aortic stenosis in their 50s. It takes that many decades for that process to really affect the valve, where they're going to need surgery and sometimes even TAVR for those people. With the mitral valve, that's less common. Sometimes for mitral valve surgery, people that get rheumatic fever, or aortic valve surgery, but mitral valve also, it takes decades also to destroy the valve. And so people will get rheumatic fever as a childhood disease, but then come in their 50s because of that childhood disease and the process that took many decades to get them to needing a procedure done.
Well, before we wrap up, we want to share that SVMHS has once again received several cardiovascular quality service awards from the American College of Cardiology and the Heart Association. And both of these organizations have evidence-based patient care criteria, and hospitals are awarded according to the quality of care performance level they achieve. Can you provide more information on this?
Well, yeah, so that's a couple of the things. And then we also have the STS database, which is one of the longest databases of information about patients. Every patient that we do heart surgery on, we provide information, and not every hospital even agrees to be a part of it. It's usually the better hospitals that really care about the quality of what they're providing to the patients. And so we've been providing our data for years, and many hospitals do. And basically, they take every aspect of the patient, all their medical problems and everything, and they turn it into a computer, and then they kind of spit out, how are you doing compared to other places? And then this year, they took our data for 3 years worth and said that, we got their highest rating, 3 stars is their highest rating for bypass surgery. And, I think it's about 5 or 10% of programs get that. So it puts us in a pretty elite group of programs. So it's we already knew we were doing a great job, but it's always good to get confirmation, especially from a database like that that's been around for so many decades. Yeah. And so it was a good honor. Well,
congratulations to you and the entire team.
Yeah, it is, and that is definitely one of the things. It's a team effort from pre-op to the ICU nurses, to the OR nurses, to all the support staff, the therapists, anesthesia. I mean, we've got physician's assistants. If you looked at the number of people that actually touch and are part of the care of an open heart patient, it's dozens. It really is amazing how many people it takes to coordinate the care of somebody after this kind of surgery. So this kind of a thing, it really shows that we've got a solid team all the way through. So it was great to get.
That's a great way to describe it, a solid team.
Yeah.
Congratulations. Again, I do want to read what some of those awards are. So we'll see them on the screen, but they are the Gold Mission, Lifeline, and STEMI Gold Award, the Gold Plus Award for Lifeline STEMI Receiving Center, the Get With the Guidelines Heart Failure Gold Plus with Honor Roll and Target Type 2 Diabetes Honor Roll, the Get With the Guidelines Stroke Gold Plus and Honor Roll Elite and Target Type 2 Diabetes Honor Roll, say that fast a few times, and the American College of Cardiology has also awarded SVMHS with the Platinum Performance Achievement Award for Chest Pain MI Registry. So that's fantastic.
Yeah, a lot of awards. So one of the things that gets looked at in evaluating heart surgery programs also is the amount of blood that may be used during the surgery, because heart surgery tends to be a part of the hospital that uses a lot of blood products. And what we found is that if you minimize or don't use any blood products, that years down the road, it can affect your survival, not just short term, but long term. And so what we have is we've implemented a blood conservation strategy where we essentially treat everyone as if they're a Jehovah's Witness, which is somebody who would refuse on any grounds, even to save their life, any blood product. And we treat everybody like that. So we only give blood in situations where we absolutely have to. And when you look at our numbers nationally, I get called from places asking, how do you guys keep the amount of blood so low on your heart surgery patients? Because we're so much below the national averages on utilizing blood and blood products. And it's helpful in all ways in the healthcare system. It's cheaper, it's better for patients, and it's just overall something that we avoid unless we absolutely have to give them.
So congratulations to the entire team.
Good team.
Fabulous team. Before we wrap up here, I think we have a fun fact, an Ask the Experts fun fact. It is February and it is Heart Month, and here we are talking about heart health. So I'll let you proceed.
Oh, sure. So we were just talking about the anatomy of the heart, and that since it was Valentine's Day and we have like our little love your heart shape, and this is an actual replica of the heart, and it's hard maybe to tell, but that outline, that's an outline of the heart, which is, here's your aorta that comes out of the heart, and it swings down, and then here's the down part of the heart here, and it swings up to the pulmonary artery here. And so this is actually, you could draw on here, like here's your aorta coming here. It's not romantic, I know, but whatever. It's like, and then here's your pulmonary artery here, and this is your ventricle here. So there's our less than romantic Valentine's fact.
But it's a great fact. I didn't know that. I'm sure a lot of you didn't, so thank you for that. You've provided really valuable information today. A fun fact.
I'll bypass this right here.
You'll bypass that. Well, thank you so much, Dr. DeFilippi, for being here today. You've provided some, I think, life-saving information, and we really appreciate your expertise, your time, and your talent here.
It's great for people to get educated about their health, and so that they can be safe and get the care they need.
Yeah, and please do not delay care. very important. You heard it here from Dr. DeFilippi as to what he has been seeing at the hospital. And you at home, thank you so much for watching. Please share and like this video. We appreciate it. We'll see you next month. I'm Claudia Otero. Thank you for joining us. Love your heart, because we do.